Hello, this is Jeff Odenbach. I'm one of the ICU fellows at the University of Calgary with an interest in critical care ultrasound. This is a brief tutorial on the use of ultrasound guidance for the placement of a radial artline. You may ask yourself, why bother using an ultrasound for a procedure that's been done in the ICU for a long time without much trouble? It's not uncommon to place 4 or 5 of these catheters on a busy ICU call shift, so I was curious to see if routine use of the ultrasound would be helpful in minimizing procedure time, minimizing complications, and number of attempts needed per procedure. So I did a brief literature search to address these questions. This is an example of one of several studies that looked at comparing blind technique versus ultrasound guidance in the placement of these lines. In about 400 catheters placed by senior anesthesia residents in elective surgery cases, they found an overall faster duration of procedure by about a minute with fewer attempts and a higher overall success rate using the ultrasound. There were a number of other studies as well as a meta-analysis that found similar findings and are included at the back of this presentation. I think it's also important to mention that it's important not to become dependent on technology for a procedure that you can do blind as well. Sometimes ultrasound machines are being used in other patient rooms or are unavailable due to repairs, and it's important to maintain your skill set to be able to do this procedure without the ultrasound. Setup for the procedure is relatively straightforward and largely mirrors what you would use for blind technique. The materials you'll need are personal protective equipment including sterile gown and gloves, chlorhexidine skin prep, sterile drapes, local anesthetic, the artline kit, as well as suture and dressing supplies. You'll also need an ultrasound machine with a linear high-frequency probe as shown in the picture on the right, and a sterile ultrasound probe cover. The patient's hand is placed in supine fashion, and you'll place the probe transversely just proximal to the wrist as shown. This is a representative picture of the anatomy you might expect to see. Here you can see the radial cortex as shown in yellow in the bottom left of the screen, with the overlying radial artery laying proximal to this. This is shown in the near field of the screen. You'll also see a pair of radial veins on either side of the radial artery. However, these are often compressed with any light pressure of the probe against the skin. Medial to this, you can see an oval structure that's the flexor carpi radialis tendon, and it's important to avoid this when placing the radial arterial catheter, as any movement of the wrist will subsequently result in kinking or displacement of the arterial line once it's in. Next, we'll ensure patency of the radial artery by either pressing gently with the ultrasound probe against the skin to see the pulsatile nature of the artery. This can be seen in the box to the left. You can also use color flow to see what the arterial waveform will look like if it's open. This is shown on the box on the right. Next, it's good practice to make sure that the ulnar artery is also patent using similar technique. You can slide the probe towards the ulnar aspect of the wrist to visualize the ulnar artery to make sure that there's good collateral flow here before proceeding with instrumenting the radial artery. Next is to administer local anesthetic with 1 to 2 cc's of plain lidocaine, and it's helpful to use the ultrasound machine to find an area of the radial artery that's nice and straight so that there's no kinking or bending when you're advancing the guide wire, and then to first topicalize the distal portion followed by the proximal portion so it can all be done in one poke. Be sure to cover both the area that you're going to use to insert the seeker needle as well as the area that you're going to subsequently put the skin sutures in after placement of the catheter. Next, we will place the seeker needle into the radial artery. This is the most important part of the procedure. It's crucial to follow the tip of the needle when you do this part. This is done by advancing the probe of the ultrasound machine forward as the needle is advanced. You can see in the video here that the probe of the ultrasound machine is advanced a couple of millimeters ahead of where the ultrasound beam is so that the needle tip isn't quite visible on the screen prior to the needle being advanced forward. What you should see on the ultrasound screen is the echo-dense bright dot of the needle showing in and out of the screen as it advances closer and closer towards the radial artery. This is a representative series of pictures that you'll see as the needle is advanced throughout the skin deep towards the artery. In the top left, you see the echo-dense seeker needle shown by blue as it approaches the radial artery shown in red. Moving from left to right, top to bottom, you'll see the needle advance to the deep subcutaneous tissue in the second panel, the arterial adventitia in the third panel, and finally in the arterial lumen in the fourth panel. Here you should see return of arterial blood through the seeker needle, confirming its placement properly. One of the biggest challenges people encounter when using the ultrasound to correctly place the seeker needle is that they have a hard time following the needle itself. This is usually as a result of not being able to visualize the needle as it goes through the subcutaneous tissues towards the artery. The most common reason for this is that the probe is not perpendicular to the needle itself. It seems intuitive to have the ultrasound probe as shown in the bottom panel where it's perpendicular to the skin. However, remember the needle is not parallel to the skin, and that keeping the probe in this orientation will not result in a perpendicular lie of the probe relative to the needle, and it won't show up well on the screen. If you have the probe angled like you see in the top panel of the skin, it'll be perpendicular to the needle and will light up nice and brightly on the ultrasound screen. After flash black of arterial blood, advance the guide wire through the seeker needle, and it should go freely and with minimal resistance as it goes down the arterial lumen. You can then confirm placement of the guide wire after the needle's removed with the ultrasound in longitudinal fashion. Here you can see the radial artery outlined in red, with the guide wire going from right to left, superficial to deep as it enters the radial artery lumen. One problem people often encounter is that after placement of the seeker needle, the guide wire has a hard time advancing. This is sometimes due to the guide wire bouncing off the posterior wall of the radial artery and can be minimized by using a shallower approach angle that also makes it easier to see with the ultrasound machine. The final step of the procedure is the advancement of the catheter over the guide wire. This should also be done with minimal resistance and the guide wire removed after the catheter inserted. You can confirm its placement by transducing a pressure waveform of the arterial catheter after it's placed. That concludes the tutorial for the placement of a radial arterial catheter with ultrasound. Thanks for watching.